Hello, everyone, and thank you very much for joining us today. My name's Deborah Garlick from Henpicked Menopause in the Workplace and Menopause Friendly Accreditation. And happy World Menopause Day week. I'm sure it's going to be the most exciting that we have ever had, and that is absolutely amazing. So do keep talking about menopause, not just on World Menopause Day, but this for us is something that we talk about every day throughout the whole of the year. And one of the things that continually we get questions around is HRT. So it's my pleasure to welcome back Dr. Clare Spencer, who is a regular on our Lunch and Learns and an absolute favourite on our Lunch and Learns, actually. And we're going to be delving into the most frequently asked questions. So please do use the chat. My wonderful colleague Michelle is in the background and she will be hopping on later. So if you've got a question, do ask that question in the chat and we'll come straight back to you. But welcome, Clare, and happy World Menopause Day.
Yes, happy World Menopause Day. It's a bit like Merry Christmas in the world of menopause, isn't it? Yes. Thank you so much for inviting me back. It's such a pleasure to be talking to you this morning.
Well, thank you, Clare, because HRT is a huge theme. Always, every training session that we run in every workplace, we always get a lot of questions about HRT. And we know people worry about it. They worry about the risks. They don't understand the benefits or the developments. And of course, it's something that's regularly on media or on programs and things. And that can sometimes muddy the water. So we thought it's a perfect time. And the theme for World Menopause Day this year, of course, is HRT. So if I can start right at the beginning and say, what actually is HRT and what does it do?
Yeah, that's a great question to open out with. So HRT stands for hormone replacement therapy. And if we just take a step back just for one moment and think about what's happening in that menopause transition. So basically, our estrogen levels go from a nice rhythmical up and down every month to the troughs of estrogen are deeper. In the perimenopause, you get big fluctuations of estrogen. At the perimenopause, at times, you can fleetingly get levels of estrogen that are a bit higher than they would have been before. And then in the menopause, as periods stop, your estrogen level is low and it stays low forevermore. And so hormone replacement therapy primarily is aiming to give back just enough estrogen to fill in some of those deep troughs in the perimenopause and just lift the level slightly in the postmenopause, enough to manage symptoms of the menopause transition and reduce the long-term health consequences of the menopause, which for most women going through the menopause at an average age will be mainly heart disease and osteoporosis.
Thank you very much, Claire. It can be a roller coaster, can't it, during the perimenopause on the run up to our period stopping. But to be clear, HRT is a regular dose that you take all the way through. So it kind of just smooths that transition a little.
Yes, no, absolutely. So the mainstay of HRT is estrogen. And yes, it is lifting the level slightly in the perimenopause. You will still get, well, most women will still get some hormone fluctuation around that raised level. And then that obviously goes on into the postmenopause where you stop having the big fluctuations, but you can still carry on having symptoms as your body is adapting to the new state of low estrogen. And so the HRT just helps manage that while you take it. And if we have our womb, if we have not had a hysterectomy, we need another hormone alongside the estrogen called a progestogen. And that's because estrogen can thicken the womb lining. And if you thicken the womb lining, that does increase the risk of abnormal cells and cancer of the womb lining. So we take an appropriate dose of progestogen alongside the estrogen so we don't have that risk.
The only reason I was asking that is somebody said to me the other day, when you see all of these ups and downs of the fluctuations, how much HRT do you take for that day when it's really high and that day when it's really low? And it's like, actually, no, it doesn't work like that. So it was a lovely description.
Yes, no, that's a great way of talking about it and describing it. So even if you're on HRT in the perimenopause, I think it's important to know that most women will still get some ups and downs of symptoms. The HRT doesn't flatten the whole system. But it's just knowing that, okay, tomorrow you might feel better. It's quite tricky to try and chase symptoms with changing doses of HRT. It's better to keep a static dose and also know what the other ways are of helping manage your symptoms for you.
Absolutely, because of course it's well, personal view, it's not the panacea for everything. You've still got to consider your lifestyle approaches, and it's a really good time to take an audit and say, actually, is my nutrition right? Is my exercise right? Am I managing my stress levels? Rather than just think one patch and absolutely everything's fine.
It would be great if it would, wouldn't it? But no, absolutely. Menopause management is not one size fits all, as we've said. And HRT is great for most women, but it might not take away every single symptom. And looking at your lifestyle and other factors can be really important as well, on top of and as well as the HRT.
Absolutely. So you kind of have to be a bit realistic about it.
Yes.
Before I move on to the benefits, one of the things, and I know you and I talk about this, and we talked about this every time a new product comes out, because I do a happy dance whenever I see a new product come out, because, back in the day, it was really one type of HRT, whereas today there's different brands, there's different doses, there's different delivery methods. And even now this year we got the Viosa. Is it Viosa?
That's right, Viosa.
So can you tell us a little bit about some of those different products?
Absolutely. And I can show you some also. So let's think about estrogen first. So in the olden days, there was basically an estrogen tablet that was often Premarin, which is conjugated equine estrogens derived from the urine of pregnant mares. We virtually never prescribe that now. What we're prescribing is estradiol, which is the same as our most potent estrogen. And so I'm showing a pump of estradiol, which many people take. You can take estrogen as a gel, either in the pump or in a little sachet. You can have estrogen. I'm just showing the spray that you spray on your forearm. So that's more of a liquid in a spray form. You can have estrogen. I'm just showing a twice weekly Everil 75 patch, or there are weekly patches, or as I said, you can swallow estradiol in tablet form. And in terms of then progestogens, you can swallow micronized progesterone. I'm just showing a strip of the little round capsules there. That's micronized progesterone, body identical progesterone. You can have a Mirena coil fit. And again, I'm just showing a little diagram of the Mirena sitting in the cavity of the womb there. Or you can have the progestogen as a separate tablet, or you can have a capsule that has the progesterone mixed in it. So lots of different permutations. And you mentioned Viosa, that's actually not a hormone. That's a tablet that works on the thermoregulatory bit of your brain. So the bit of your brain that controls our temperature. Viosa is fezolinetant, which is a new medication which can help hot flushes and night sweats, that actually is not a hormone, to add to the armory of alternatives to HRT. But it's great that there are a number of different options now, aren't there? It's so good that women can choose and mix and match.
Yeah, and
it suits them.
Absolutely. And one of the frequently asked questions that we get is that, well, I tried it once and it didn't really work for me. And it's like, well, which one did you try? There are lots of different brands. Some things might suit you better than other things. So, you can actually mix and match to find something that works best for you.
Absolutely. Some women may react to the adhesive and patches and it can cause skin irritation, or maybe the patches aren't sticking. So maybe gel would be better therefore. But gel takes 5 minutes to dry. If you're hurtling around in the morning at 90 miles an hour, maybe waiting 5 minutes for gel to dry is not ideal in your lifestyle. So maybe a patch might be better, or even a tablet. Spray takes a couple of minutes to dry, but like gel, you need to stay dry for a couple of hours after. If you love your swimming or a shower before bed, maybe that's not right. So maybe a patch. So you can see the conversations that we have. Some people absorb better from one method than another. There's usually no way of really predicting that. So somebody whose symptoms aren't controlled with a patch, actually they may be better with spray or gel, or vice versa. It really is a start something, have a conversation, have a review, let somebody listen and work out what's best for you.
Yeah, because you can't always assume that the first one you're going to get, there might be a bit of trial and error.
Totally, completely. Start with something, see how you go, be prepared to be flexible, move on. It may be the first dose isn't the right dose. You might need to increase it. You might need to decrease it. Yeah, absolutely.
Absolutely, but it's worth it, isn't it? Because if your hormone if your perimenopause and your symptoms are lasting a while, that bit of time can make a huge difference. I think I'm on my 4th different one. The first one was absolutely perfect. The second one, and they put me on the tablets, which gave me huge painful boobs. And I thought, I just can't cope with this. So I couldn't even manage the full 3 months because they said, let's see if it settles down.
Yeah.
I have the gel now. And for a brief period during COVID, when the gel ran out or it was in short supply, they put me on the Lenzetto spray. But then we couldn't get hold of that, so we went back to the gel. And the gel's fine, actually. It works well for me. So and I've been taking it for 15 years, so I've probably got quite a history with it. But that long period of time, finding or taking the time to find what works best for you is worth it.
Totally and utterly. And getting the right advice, also finding out who the best person in your practice is, speak to somebody like myself or one of my colleagues. Yeah, absolutely. Get the right advice for you also.
Yeah, thank you, Claire. And so, of course, which leads me on to the risk element, because there's different views around this, but I can guarantee somebody will always say, does HRT give you cancer?
Really important to understand there are really small risks to using HRT. So breast cancer is obviously at the forefront of women's minds, understandably. Population risk of breast cancer is 1 in 7, 1 in 8, depending on studies. So, it is on the forefront of our minds. And HRT does increase the risk of breast cancer diagnosis by a really small amount. And if we think back to the early 2000s with the Women's Health Concern, Women's Health Initiative study, that showed that over 5 years, there was a background risk of diagnosis of breast cancer for women in their 50s of 23 cases per 1,000. And then when you added the old style HRT onto that, so I'm stressing the old style HRT here, there were 4 additional cases per 1,000 diagnosed over a 5-year period. But actually, bearing in mind that 23 case per 1,000 background risk, the women who were very overweight or obese with a body mass index of around 30 or more, there were 24 additional cases of breast cancer. So that more than doubled the risk. You can still, from that statistic, the vast majority of women were not diagnosed as having breast cancer. But if we put the risk into perspective, it's important to consider it. And we're not diminishing the impact of a diagnosis of breast cancer by any means, but it, in relative speakingly terms, is really low.
Thank you very much. And are there other risks? Because I think some people that have got blood clot history or things might have to be more careful.
No, absolutely. So if you swallow estrogen, it probably doubles or more than doubles your risk of blood clots of legs, lungs, stroke. So not inconsiderable health factors, health risks. But if you have the estrogen through the skin, it doesn't have any impact on risk. Now, again, for most healthy, not overweight, not smoking, not had a blood clot before women, what that doubling of risk means that you go from a tiny risk to a higher tiny risk. But if you have any risk factors for blood clots or you're concerned about it, then if you have the estrogen through the skin transdermally, there is no additional risk that we're aware of.
Right. And I know, because I can see one of the questions has come up about somebody that's had a cancer diagnosis in the past. Is this something that is possible for them?
It depends what type of cancer. So if it's a hormonal dependent cancer, like a hormonal breast cancer, then the issue is we just don't know exactly what the risks of HRT are in numerical terms, but HRT it is really likely to increase the risk of recurrence of breast cancer. So if you want to take HRT, if you've got really horrible symptoms, then it's so important that you have a discussion with somebody who's aware of the evidence and can talk that all through with you, who liaises with your cancer specialist also.
Okay.
Other types of cancer, particularly not hormonally dependent cancer, then it's really likely that you can take HRT. It's just you need to speak to somebody or get referred to somebody who's able to sort of process and understand what the evidence is and talk to you about the risks and benefits ratio of how the HRT applies to you.
Absolutely. Thank you, Claire. And I'll move on to the benefits because we've covered the risks. What are the benefits of HRT?
Yes, so HRT for most women is the most effective way of managing symptoms. It just is, it's not going to, as we said earlier, cure everything, but it's very effective at managing symptoms. It can significantly reduce the risk of osteoporosis. It can help increase bone density if you have thinning of the bones, osteopenia or osteoporosis, and clearly helps reduce the risk of fracture if you have osteopenia or osteoporosis. And we know that it's really clear that it reduces the risk of heart disease also, which for women is, a really important cause of mortality. So they are the two main benefits, along with symptom management. And also, we haven't really mentioned vaginal estrogens, which can also, vaginal estrogens manage vaginal symptoms and bladder symptoms, as well as systemic HRT.
Thank you very much, Claire. I'm glad that you said that because people just assume that it's all about symptoms management. But it's, this time of life, we're living longer, hopefully. What is the average age at the moment? Mortality 83. You could live long beyond that. So it's not just about this managing symptoms during the transition. It is thinking about long-term health as well. And HRT does have some proven benefits in that way too.
It absolutely does. And I think on that note, also, if you are going through the menopause under the age of 40, or particularly under the age of 45, then it's so important that you do take HRT, that you don't have increased number of years without estrogen, because those health risks become higher. And for women under 40, also maybe increased risk of dementia also. So yes, absolutely important to consider it. Yeah.
Thank you very much, Claire. Well, I can see the chat's going crazy, so I'll invite my colleague Michelle to join us. But one thing I would say is that we always get is getting an appointment at your GP surgery.
Yes, can be really challenging. Yeah, particularly at the moment. So ask at your GP practice who the best person to talk about menopause and HRT or just menopause is. And it may be a GP, it might be a pharmacist, it might be a nurse practitioner or a practice nurse. But usually if you ask around within your community or ask the receptionist, they're usually good people to ask and try and see somebody who's got a little bit more knowledge. Because at the end of the day, GPs are GPs, but there should be somebody in each practice now who's got extra training or extra knowledge.
Absolutely. And I know I shouldn't, but it's I'm not promoting here, but My Menopause Centre is, of course, outstanding as far as CQC is concerned. So if you are thinking of going private, you do look for, because the CQC Outstanding Award is actually pretty rare, isn't it?
I think we're the only menopause clinic with CQC outstanding. There are lots of menopause clinics out there and lots with good, but we are but thank you so much for mentioning that.
Well, I'd only say that because some of us can't wait for the NHS. I know I went private because, well, actually, I think it was my husband that couldn't wait for me to get sorted. But it was kind of one of those things, and finding a good practice is important if you are going to invest in going private. And then now I'm plugged back into the NHS, who continue to look after me. But that's one of my little tips. Michelle, I could see lots of questions coming through.
There have been. So one that covers quite a few. If you're taking a progesterone, HRT, and it's got to coordinate with your cycle, one of the comments that is made is that obviously our cycles can vary in length. So some people are starting to experience a bleed partway through, so they feel that they're out of sync. And then on from that, somebody's also mentioned that they started on the patches and their first period lasted 10 days. So that first introduction going, and then how is it managed going forward?
Yeah, super briefly, when you start any HRT or change dose, it's really common to get some unscheduled bleeding in the first 3 months. And as long as it settles, as long as it's not triggered by sex, as long as it's not super heavy, it's okay to wait, speak to your GP, but generally we would just wait and see. Right, second bit. So if you're taking sequential HRT in the perimenopause and you've been told to take the progesterone capsules from day 15 of your cycle, it's a nightmare trying to time that if you're having irregular bleeding. So I tell women to take it so if you're taking 2 for 12 nights, start it either on the 1st of the month and take it till the 12th. The key thing is that you take 12 nights worth every month, and it's better to do it in a rhythm, in a routine. So you can arbitrarily start it from the 1st of the month and take it to the 12th of the month. Sometimes if women's periods are not mega irregular, you know, they are having one every 5 or 6 weeks, I'll say, right, when was your last period? Work out when day 15 is, if day 1 is the first day of your period. Say that arbitrarily is the 10th. Say it was the 10th of October. Forevermore, I say start it on the 10th of every calendar month. It doesn't matter if you start to bleed before you've finished taking them. It doesn't matter if it waits a few days till you bleed. It doesn't really matter if you don't bleed as long as you're not pregnant. Just make sure that you are taking it from approximately the same time of every month. Because I speak to some women and they say, you know, I'm having a bleed every 6 weeks. When do I start it? Or that it's starting erratically. Do I stop it? Do I count that day? It's really difficult. So they are my top tips.
Okay, that's excellent. Just a reminder to everybody, because we've been asked about recordings, we'll be watching this available on the Menopause Hub on henpicked.net. So lots of opportunity to go back over things as well.
Yeah, and so can I just briefly interrupt and say, don't change anything before talking to your doctor, but you could suggest to your doctor that you do what I've just suggested. Yeah, sorry.
Excellent. Okay. Contraindication with other medications. So if you're on blood thinners or blood pressure tablets, or actually take herbal remedies for sleeping or anxiety, where does everything fit together, and who are the best people to ask help for?
Yeah, so there are relatively few interactions with other medication. There are some really key ones. So some HIV medication interacts with HRT, and there is one anti-epileptic called lamotrigine that HRT might impact on the blood levels of lamotrigine, and some epileptic drugs can make HRT a little bit less effective. That is not a comprehensive list. They're just some examples. So start with your GP or your specialist. So if you're under an HIV specialist, under a neurologist, or speak to the GP, and they'll be able to look up the interactions on. We have a couple of websites that we use as GPs and can work out if there are going to be any important interactions.
Okay, so changing from one type of HRT to another. So there's a lot of people here talking, some take gels, some take sprays, some take tablets, all sorts of different ways. Jumping from one to another, I know when we've talked before, you know, what's that time scale we should wait until we go, oh, let's try another version and see if that works?
Yeah, so if you can hang on for 3 months, it can take 3 months for a dose to settle. But as Deborah said earlier, if you've got really horrible breast tenderness and you can't let anybody, let alone the bra, close to your boobs, You do not have to put with horrible symptoms for 3 months. But the rule of thumb is if you can wait for 3 months to increase or change a dose. I talked to some women and they've been chatting on forums, and they'll increase and decrease their doses of gel quite quickly. But I try and encourage you not to do that, because if you go quickly up to high doses of gel, you may actually downregulate estrogen receptors, and it can become a bit less effective. So it's best to, number one, do it with medical advice, and number two, if you can wait, then do wait.
And just taking that to just that little bit further, if somebody is having problems absorbing the gel, which we know can occur, and they go onto the patch, can you simply stop the gel, if we work on 3 months and then you go to your GP, can you simply change from the gel to the patches without any break?
Yes, you can. It's not like some antidepressants where you need to taper off one dose and slowly start another. You could literally switch from gel to a patch. You usually look at the equivalent doses. So 2 pumps of estrogel is equivalent to a 50 microgram patch, which is equivalent to 3 sprays of Lenzetto. But sometimes you might start at a lower dose again and work up. It all depends on symptoms, how bad they are, what the dose is. It's really variable.
So quite a few people asking, they've had treatment for endometriosis, there's endometriosis in the family, BRCA genes, etc., etc. How do they start to even begin to have a conversation, having been perhaps told from their GP, absolutely no way now? How there's some comments here that it can awaken your endometriosis if you go on HRT. Where do the people like this turn?
Yeah, so around the UK, there will be referral into specialist menopause services. Sometimes it might be a gynecology service. Sometimes, like for example, where I work, patients can get referred from their GP if they live, say, within Leeds, into our specialist service. So don't be afraid to question. And don't be afraid to go with your own information, and don't be afraid to ask for a referral if you're not getting very far with your GP, because at the end of the day, it may be it's a bit like going with a heart issue that, your GP can do a certain amount and then need to refer. And similarly with the menopause, if there are medical complications, endometriosis, just touching on that super briefly, there is a small risk that HRT might reawaken endometriosis, but that's all about taking the right dose and the right progestogen and making sure you're on the right HRT for you. So the general answer is get referred.
Okay, thank you. And very aware of time, so very briefly,
me too.
postmenopause, HRT and postmenopause, option available for consideration and discussion?
Yes, no, totally. If the HRT hasn't helped symptoms and you're postmenopausal and they're ongoing and you're fed up, speak to somebody. You can start HRT in the postmenopause.
That is absolutely wonderful, Claire and Michelle. I think we could go on for another hour and go through the rest of the questions. But as Michelle says, this recording will be on their Henpicked Menopause Hub, and lots of others from the brilliant Dr. Clare Spencer and many others. So whatever your question, go and search in there. But thank you very much for your time today, Dr. Clare, and thank you to everyone for joining us, and of course Michelle for managing the questions. We look forward to seeing you again soon. Happy Menopause Day.